This is the audio lecture for Chapter 25, Care of the Patients with Infection. The objectives for this chapter are to explain the Centers for Disease Control and Prevention hand hygiene recommendations for healthcare workers, to control the transmission of infection through hand hygiene and transmission-based precautions, to apply the current principles of infection control, to teach the patient, families, and staff about infection control measures, to teach patients and families about antimicrobial therapy, assess patient and family response to transmission-based precautions. We're also going to identify patients most at risk for infection, including older adults, provide information to patient and family about drug therapy for infections, identify common clinical manifestations of infectious diseases, interpret laboratory test findings related to infections and infectious diseases, evaluate nursing interventions for management of the patient with an infection, and lastly, explain why multi-drug resistant organisms and other emergent infections are increasing. We know that the human body has many protective systems that promote homeostasis. Physiologic mechanisms are the structural and functional defenses that protect people from stressors such as infection. When these mechanisms fail to work properly or are overcome with microbes, infection can result. First, we're going to go over some definitions. Blank is any microorganism capable of producing a disease. If you wrote in pathogen, you are correct. Blank is an infection transmitted from person to person. The answer to that is communicable infection. Blank is the ability to cause disease. That is pathogenicity. Blank is the degree of communicability. The answer to that is virulence. Let's continue with definitions. Blank is characteristic bacteria of a body location. It often competes with other microorganisms to prevent infections. The answer is Norma flora. Blank, the microorganism present in tissue but not yet causing symptomatic disease. The answer, colonization. Our next definition, blank, the tracking and reporting of infections. The answer is the CDC, or the Centers for Disease Control. The CDC, they control their infection control practitioner is responsible for surveillance and ensuring compliance with federal and local requirements. In this slide, we're going to do an overview of the chain of infection. This all should be a review for you guys. I know you've heard this many times, probably starting with microbiology. Transmission of infection in healthcare requires 3 factors. Those factors include a reservoir or source of infectious agents. Your reservoirs can be animate reservoirs, including people, animals, and insects, or they can be inanimate reservoirs, which include soil, water, and other environmental sources, and medical equipment that you see in the hospitals, such as your IV solutions, your urine collection devices, your pumps, any medical equipment that we use in the hospital. The second thing you need is a susceptible host with a portal of entry. Usually in the hospitals, we do a lot of invasive procedures. That's why we teach you guys sterile techniques so that we can reduce the amount of bacteria that we're introducing into our patients or clients. And the last step we need is a mode of transmission. To continue with the overview of chain of infection, we must have pathogens, and a pathogen is any microorganism, also called an agent, which is capable of producing disease. Pathogens include bacteria that invade the bloodstream or cerebrospinal fluid, for example, Enterococcus. A toxin is a protein molecules released by bacteria to affect the host cell at a distant site. Exotoxins, they're produced and released by certain bacteria into the surrounding environment. Endotoxins are produced in the cell walls of certain bacteria and released only with cell lysis. Host defenses provide the body with an efficient system for protection against pathogens. Breakdown of these defense mechanisms may increase the susceptibility risk of the host to infection. And we're going to take like 5 seconds, and I want you guys to think of some things that causes a person to be more susceptible to infection, whether it's medical or physiologic. I think you guys should be able to come up with at least 4 or 5 things, and we'll talk about it in class on Tuesday. When we're talking about infection, we must also include the role that immunity plays. Immunity is the resistance to infection. It's usually associated with the presence of antibodies or cells acting on specific microorganisms. Depression of the immune system may make hosts more susceptible to infection or cripple the ability to combat organisms that have gained entry. What are some medical problems that may cause a decrease in a person's immune system? Some examples include HIV, human immunodeficiency virus, age, usually my geriatric patients, they're more susceptible, and anyone who is born with or inherits any type of autoimmune disease, those people usually have a lower immune system and lower immune response to infection. When speaking of immunity, it's broken down into two main categories: passive immunity or active immunity. It's broken down even further, but for this lecture we're just going to do the major two. So passive immunity is of short duration. It's either naturally by placental transfer, so from mom to baby, or artificially by injection of antibodies. If you've ever had a patient who is immune compromised, and we may give them IgG, IgA, which are immunoglobulins that we put in via IV. Active immunity lasts for years and occurs naturally by infection. So if we've had an infection before, our body builds antibodies. So the next time we get that same infection, we have antibodies that are directed towards that that infection, and it automatically starts the immune process in fighting off that infection. Or by stimulation of immune defenses, which is with our vaccines. And all of you guys know about vaccines because you are required to get your vaccines for nursing school. Environmental factors can influence immune status. People who are consume large amounts, well, not even large amounts of alcohol, but alcohol consumption in general. My nicotine users or smokers, and people born with certain vitamin deficiencies. Malnutrition, especially protein calorie malnutrition, places patients at increased risk for infection. Also, diseases such as diabetes mellitus, which we'll learn about later on in the term, also predispose the patient to infection. And like I said, my older adults, they have decreased immune systems as well as other physiologic changes that make them very susceptible to infection. Next, I'm going to play a video that goes over immunity and how the immune system works and how it responds when there is an attack of some type of pathogen on the human body.
Trillions of microbes ready to invade our bodies lurk in the air, the water, the foods we eat, and on the objects we touch. Nevertheless, most of us are healthy most of the time and unaware of the constant battle between body and microbe. Even when infections occur, we almost always fend them off quickly. Our usual state of good health is due to three lines of defense: external barriers that keep microbes out of the body, non-specific internal defenses that combat all invading microbes, and our immune system, which assaults specific microbes. The body's first defense against microbes are the skin and the mucous membranes of the digestive and respiratory tracts. The dry, dead cells, filled with hard proteins that cover the outer surface of the skin, prevent most microbes landing on the skin from obtaining needed water and nutrients, while acids and natural antibiotics secreted by the sweat and sebaceous glands actively inhibit the growth of bacteria and fungi on the skin. The membranes of the digestive and respiratory tracts are protected by mucus, which contains antibacterial enzymes that destroy the cell walls of bacteria and physically traps microbes that enter the body through the nose or mouth. Cilia on the membranes sweep up the mucus, microbes and all, until it is either coughed up, sneezed, or swallowed. Swallowed microbes enter the stomach, where they encounter a combination of extreme acidity and protein-digesting enzymes that kills many microbes. Farther along the digestive tract, bacteria harmless to humans secrete substances deadly to other invading bacteria or fungi. Though these defenses are good, the warm, moist mucous membranes are more vulnerable to invasion than the skin. Disease organisms that enter the body through the skin or mucous membranes run into three non-specific internal defenses: standing armies of phagocytic and natural killer cells, the inflammatory response, and fever. Monocytes and neutrophils are phagocytic white blood cells that travel through capillaries to wounds where bacteria have gained entry, then ooze out through narrow openings in the capillary walls. After leaving the capillaries, monocytes differentiate into macrophages, amoeba-like cells that engulf and ingest bacteria and other foreign particles. Neutrophils, the most numerous of white blood cells, like macrophages, also engulf foreign invaders such as bacteria and certain fungi. Both monocytes and neutrophils secrete molecules that attract other defensive cells to the invasion site. Natural killer cells are another class of white blood cells. They do not directly attack and engulf invading microbes, but rather identify and destroy body cells that have been invaded by viruses or that have become cancerous. Sensing molecular changes, natural killer cells bind to the compromised cell's cellular membrane and release proteins that pierce holes in it. Cytotoxic proteins then ensure the destruction of the abnormal cell by entering it and destroying its nucleus. Breaches of the skin or mucous membranes elicit an inflammatory response. Damaged cells release the chemical histamine into the wounded area. Histamine makes capillary walls leaky. Leaky capillaries cause fluid to seep from the capillaries into the tissues around the wound. The wound becomes red, swollen, and warm. Meanwhile, other chemicals released by injured cells initiate blood clotting that both blocks damaged blood vessels, preventing microbes from escaping into the bloodstream, and seals off the wound from the outside world, limiting the entry of more microbes. Still other chemicals, some released by wounded cells and others produced by microbial invaders, attract macrophages, neutrophils, and other phagocytic cells to the wound, where they engulf microbes, dirt, and tissue debris. The pus that collects around a wound consists largely of microbes, tissue debris, and living and dead white blood cells. If enough microbes survive the inflammatory response and infect larger areas of the body, a fever may be triggered. While severe fevers are dangerous, even fatal, average fevers of 38 or 39 degrees Celsius, 100 to 102 degrees Fahrenheit, are beneficial. In the brain, the hypothalamus contains temperature-sensing nerve cells that normally set the body's thermostat at about 37 degrees Celsius or 98.6 degrees Fahrenheit. However, certain white blood cells, in response to infection, release hormones called endogenous pyrogens that cause the hypothalamus to trigger behaviors that increase body temperature, shivering, increased fat metabolism, and a feeling of cold that causes a search for heat and warmth. The release of pyrogens also results in reduced iron concentrations in the blood, which, combined with the fever, slows the reproduction rate of many bacteria. Further, fever increases the activity of the phagocytic white blood cells that attack bacteria. Fever fights viral infections by increasing the production of the protein interferon, which is synthesized by certain body cells when they are invaded by viruses. Interferon released by these cells travels to other cells and increases their resistance to the viral attack. While often effective, these non-specific defenses are not impregnable. When they fail to do the job, the body then mounts a highly specific immune response directed against the particular organism that has successfully invaded the body. More than 2,000 years ago, the Greek historian Thucydides recognized that occasionally someone contracts a disease, recovers, and never catches that particular disease again. The person becomes immune. With rare exceptions, however, immunity to one disease confers no protection against other diseases. Thus, the immune system attacks one type of microbe, overcomes it, and provides future protection against that microbe, but no others. This is why we refer to the immune response as a specific defense against invasion. The immune system consists of about 2 trillion specialized white blood cells called lymphocytes. Many are distributed throughout the body in the blood and lymph. Others are clustered in specific organs, particularly the thymus, lymph nodes, and spleen. The immune response results from the interactions among several types of lymphocytes and the molecules they produce. The immune response is provided chiefly by 2 types of lymphocytes, B cells and T cells. As with all white blood cells, B and T lymphocytes arise from cells in the bone marrow. Early in development, newly forming T cells migrate to the thymus, hence the name T cell, and differentiate. B cells differentiate in the bone marrow itself, hence the name B cell, and later migrate typically either to the spleen or lymph nodes. Immune responses produced by both B and T cells consist of 3 steps: recognizing invaders, launching an attack, and retaining a memory of the invader to ward off future infections. To understand how the immune system responds to invading microbes, 3 questions must be answered. How do immune cells recognize foreign molecules? How do they produce specific responses to so many different molecules? And how do they determine that a substance is foreign and not self, thereby avoiding destruction of their own body tissues? The key to the immune system's ability to attack invading microbes lies largely with proteins called antibodies and T-cell receptors. Antibodies are either attached to the surfaces of B cells or dissolved in the blood plasma, where they are called immunoglobulins, often abbreviated IG. T-cell receptors are only found attached to the surfaces of T cells. Antibodies are Y-shaped molecules composed of 4 peptide chains, 1 large, heavy chain, and 1 small, light chain on each side of the Y. Both heavy and light chains consist of a constant region that is similar in all antibodies of the same class, and a variable region that differs among antibodies. The combination of light and heavy chains results in an antibody with 2 functional parts, the arms, and the stem of the Y. The variable regions on the arms form highly specific binding sites for large molecules. Each binding site has a particular shape and electrical charge, so only a few, or perhaps only one type of molecule can fit in and bind to the site. In general, only large, complex molecules, such as proteins, polysaccharides, and glycoproteins, bind to antibodies. These molecules, or antigens, may either be attached to the surfaces of cells, the body's own or invading microbes, or dissolved in the blood or extracellular fluid, such as snake venom. As we will discuss shortly, the binding of antigen to antibody triggers the immune response. The stem of antibody molecules, which consists of part of the constant regions of the two heavy chains, determines the activity of an antibody. Though the constant regions in different antibodies are similar, they are not identical. For example, the heavy chain constant regions forming the stem of one type of antibody may attach the antibody to the plasma membrane of a cell. The constant regions of another type of antibody may bind to certain proteins in the blood, called complement, to promote the destruction of microbes.
Portal of entry sites. Microorganisms may enter the body in a variety of ways, including the respiratory tract, GI tract, genitourinary tract, skin and mucous membranes, and the bloodstream. Pathogens may enter the body through the respiratory tract. Microbes and droplets are sprayed into the air when people with infected oral or nasal tissues talk, cough, or sneeze. Other pathogens enter the body through the GI tract. Some stay there and produce disease, while others invade the GI tract to produce local and distant infection. Millions of foodborne illness cases occur each year in the United States. This type of illness results in many hospitalizations and deaths. Microorganisms also enter through the genitourinary tract. Urinary tract infections is one of the most common healthcare associated infections. This is why we have definitely seen a decrease in the use of urinary catheters, both inpatient, outpatient, and in long-term care facilities. Although intact skin is the best barrier to prevent most infections, some pathogens can enter the body through intact skin or mucous membranes. Most enter through breaks in these normally effective surface barriers. Sometimes a medical procedure creates a break in cutaneous or mucocutaneous barriers. The fragile skin of older patients and of those receiving prolonged steroid therapy increases infection risk also. Microorganisms can gain direct access to the bloodstream, especially when invasive devices or tubes are used. The incidence of bloodstream infections continues to increase in hospitals throughout the United States. Our central venous catheters are the primary cause of these infections. Mode of transmission. For infection to be transmitted from an infected source to a susceptible host, a transport mechanism is required. Microorganisms are transmitted by several routes, such as contact transmission, by direct contact of a source and host have physical contact, or indirect contact where the source to host by passive transfer from a contaminated object. Droplet transmission such as influenza, which can be passed by talking or sneezing of a person with the infection. Or it can also be airborne transmission, such as in tuberculosis. With the airborne, we have small airborne particles containing pathogens leave the infected source and enter the host. Back to contact transmission. Contact transmission is the usual mode of transmission of most infections. Many infections are spread by direct or indirect contact. Direct contact, the source and host have physical contact. The microorganisms are transferred directly from skin to skin or from mucous membrane to mucous membrane. is often called person-to-person transmission, and it can be best illustrated by the common cold. Indirect contact transmission involves the transfer of microorganisms from a source to a host by passive transfer from a contaminated object. The contaminated articles or hands may be the source of the infection. For example, patient care devices like your glucometers and electronic thermometers may transmit pathogens if they are contaminated with blood or body fluids. Droplets are produced when a person talks or sneezes. The droplets travel short distances. Susceptible hosts may acquire infection by contact with droplets deposited on the nasal, oral, or conjunctival membranes. Therefore, the CDC recommends that staff stay at least 3 feet away from a patient with droplet infection. Like I said, an example of droplet infection is the influenza or the flu. Airborne transmission occurs when small airborne particles containing pathogens leave the infected source and enter a susceptible host. These pathogens can be suspended in the air for a prolonged time. The particles carrying pathogens are usually contained in droplet nuclei or dust. They are usually propelled from the respiratory tract by coughing or sneezing. A susceptible person then inhales the particles directly into the respiratory tract. And one of the main examples we have for airborne is tuberculosis. And we all know that as a student, you will not be able to take care of a patient with suspected tuberculosis because we have to be fitted for a special mask called the N95. And since hospitals don't routinely test fit students, we are not allowed to take care of those patients. Other sources of infectious agents include the environment, such as contaminated food, water, or vectors. And vectors are insects that carry pathogens between 2 or more hosts. The portal of exit completes the chain of infection. Exit of the microbe from the host often occurs through the portal of entry. Physiologic defenses against infection. Strong and intact host defenses can prevent microbes from entering the body or can destroy a pathogen that has entered. Impaired host defenses may be unable to defend against microbial invasion, allowing entry of organisms that can destroy cells and cause infection. The common defense mechanisms that we're going to talk about in this slideshow includes body tissues, phagocytosis, inflammation, and immune systems. And the movie or the video that I showed earlier in this lecture gave us a good look at all 4 of these defense mechanisms against infection. Body tissues. Intact skin forms the first and most important physical barrier to the entry of microorganisms. In addition to providing a mechanical barrier, the skin's slightly acidic pH, together with normal skin flora, creates an unfriendly environment for many bacteria. Phagocytosis occurs when foreign substances evades the first line of mechanical barriers and enters the body. Phagocytosis is the process of engulfing, ingesting, killing, and disposing of invading organisms. Phagocytic dysfunction dramatically increases a patient's risk for infection. Inflammation is another important nonspecific defense mechanism for preventing the spread of infection. With inflammation, tissues become damaged and releases enzymes and leukocytes, which causes the area to inflame, thus allowing fluid, proteins, and WBCs to enter. And if you want to review the video, it really talked about inflammation when there's a break in the skin and how histamine, we know it increases the permeability of the capillaries in the inflamed tissue, allowing fluid, proteins, and white blood cells to enter the inflamed area. If inflammation is caused by infection, the end product of inflammation form is pus, which is then absorbed or exits the body through a break in the skin. The immune system. Specific defense responses to specific microorganisms are provided by the antibody and cell-mediated immune systems. The antibody-mediated immune system produces antibodies directed against certain pathogens. These antibodies inactivate or destroy invading microorganisms as well as protect against future infection from that microorganism. Resistance to other microorganisms is mediated by the action of specifically sensitized T lymphocytes and is called cell-mediated immunity. The components of the immune system work both independently and together to protect against infection. Infection acquired in the inpatient healthcare setting is termed a healthcare-associated infection. When occurring in a hospital setting, they are sometimes referred to as hospital-acquired infections. Healthcare-associated infections can be endogenous from a patient's flora or exogenous from outside the patient, often from the hands of healthcare workers, tubes, or implants. Healthcare-associated infections, including surgical site infections, occur in 1 in 20 inpatients yearly, causing increased healthcare costs and many deaths. These infections tend to occur most often because healthcare workers do not follow basic infection control principle, especially aseptic technique and injection practices, and the good old hand hygiene. Methods of infection control in the inpatient setting include practice hand hygiene and proper hand washing, which includes the use of alcohol-based hand rubs. And you can only use the alcohol-based hand rubs if your hands are not visibly soiled. If your hands are visibly soiled, we want to use the good old-fashioned soap, water, and friction. Also, the use of personal protective equipment, such as your gowns, your gloves, your face mask, and your respirators, your N95 if you're taking care of a person who is suspected of having tuberculosis. And here's an excellent picture of healthcare personnel appropriately donned in their personal protective equipment. Adequate staffing of nurses is an essential method for preventing infection. In addition to a ratio of 1 infection control practitioner to 100 occupied acute care beds, nurse staffing is critical. Sterilization and disinfection have helped invasive procedures become much more common and safe. Sterilization means destroying all living organisms and bacterial spores. All items that invade human tissue where bacteria are not commonly found should be sterilized. Disinfection does not kill spores and only ensures a reduction in the level of disease-causing organisms. Patient placement has been used as a way to reduce the spread of infection. Some studies have suggested that private patient rooms help decrease infections. The CDC has not mandated that all patients, even those with infections, have a private room. The CDC does recommend that private rooms always be used for patients on airborne precaution and those in protective environments. The CDC also prefers private rooms for patients who are on contact and droplet precautions. Many hospitals are increasing their number of private rooms, and some facilities are becoming totally private facilities. The facility that I worked at, we tried that. They went to an all private room system, but it did not work for us because we were the city hospital. So we were either filling our ER with patients who needed to be transferred to the floor, or we were having to divert patients to other hospitals. So it lasted, I would say, a good 2 or 3 months, and then we went back to semi-private rooms. Cohorting is another method of patient placement. Cohorting is the practice of grouping patients who are colonized or infected with the same pathogen. This method has been used the most with patients who have an outbreak of MRSA. So typically our MRSA or our MRSA patients, we can put them in the same room. Infection control principles for patient transport include limiting movement to other areas of the facility, using appropriate barriers like covering infected wounds, and notifying other departments or agencies who are receiving the patient about the necessary precautions that need to be taken. Typically, if we have a patient who has tuberculosis or some airborne type illness, we try to limit them from leaving their room. If they have to go for a procedure, typically we will put a face mask on that patient. Standard precautions reflect that all body excretions, secretions, and moist membranes and tissues, excluding perspiration, are potentially infectious. Respiratory hygiene, cough etiquette. We now tell patients to cough into their armpit, no outwardly coughing without covering the mouth. If they want to cough in a tissue, blow their nose in a tissue, go ahead and do that. Then immediately dispose of the tissue and do good hand hygiene. In hospitals, you'll see signs that say, I know our sign says patients healing. If you have a respiratory type infection, either wear a mask, use the alcohol-based hand rub, or uh, don't visit until you're feeling better. Safe injection practices. These include using a sterile single-use disposable needle and syringe for each injection, and preventing contamination of injection equipment and medication. So I know some people at home, because of monetary restraints, they may use their insulin syringes 2 or 3 times, but in the hospitals we have an abundant source, and we only use our needle and syringes once. Transmission-based precautions. Airborne precautions are used for patients known or suspected to have infections transmitted by the airborne transmission route. These infections are caused by organisms that can be suspended in air for prolonged periods. These patients typically are put into a negative airflow room, and the healthcare provider must wear an N95 mask. Typically, airborne precautions are used for patients with tuberculosis, measles, and chicken pox. Droplet precautions are used for patients known or suspected to have infections transmitted by the droplet transmission route. Such infections are caused by organisms in droplets that may travel 3 feet but are not suspended for long periods. Examples of patients who would require droplet precautions are your patients with influenza, mumps, pertussis, and meningitis. Contact precautions are used for patients known or suspected to have infections transmitted by direct contact or contact with items in the environment. Patients with significant multi-drug resistant organisms such as MRSA, MRSA, VRE, your vancomycin resistant enterococcus, scabies, lice, RSV, we see those in kids, and C. diff, Clostridium difficile. These patients are placed on contact precautions. MRSA, methicillin resistant Staphylococcus aureus. 130,000 cases occur in hospitals each year, which leads to 5,000 deaths. MRSA is spread by direct contact and invades patients through indwelling urinary catheters, vascular access devices, and endotracheal tubes. Staphylococcus aureus is a common bacterium found on the skin and perineum and in the nose of many people. Usually it's not infectious unless it enters non-intact skin. Then minor infections like boils or conjunctivitis may occur. If it enters deep wounds, surgical incisions, the lungs, or bloodstream, more serious infections can occur that require strong antibiotics. MRSA is susceptible to only a few antibiotics such as vancomycin and Zyvox. More and more Staph aureus infections are not responding to methicillin or other penicillin-based drugs. This type of infection is called hospital-associated MRSA. Healthcare facilities have MRSA surveillance programs in which each patient's nose is swabbed and cultured for MRSA and placed on isolation. It may also include culturing each staff member. And typically, patients who are deemed at high risk of having MRSA, such as patients coming from long term care facilities or your elderly patients, they are all screened for MRSA, and we do it with a nose swab before they are admitted to the hospital. Community-associated MRSA develops in community-based healthcare agencies such as nursing homes and dialysis centers, and in group facilities or settings such as prisons, dormitories, and schools. Community-associated MRSA is a serious illness that causes skin and soft tissue infections, including abscesses, boils, and blisters. The best way to decrease the incidence of this growing problem is health teaching. That health teaching includes performing frequent hand hygiene, including using hand sanitizers, avoiding close contact with people who have infectious wounds, avoiding large crowds, avoiding contaminated surfaces, and using good overall hygiene. Other multi-drug resistant organisms include VRE, or vancomycin resistant enterococcus. Enterococci are bacteria that live in the intestinal tract and are important for digestion. When they move to another area of the body, such as during surgery, they can cause an infection, usually treatable with vancomycin, which have been resistant during the recent years. Risk factors for this infection include prolonged hospital stays, severe illnesses, abdominal surgery, enteral nutrition, and immunosuppression. Patients with VRE are placed on contact precaution. Other multi-drug resistant organisms we've seen include multi-drug resistant tuberculosis, gonorrhea, vancomycin intermediate Staph aureus or VISA, and vancomycin resistant Staph aureus VRSA have recently appeared. The first cases of VISA and VRSA have shared some of the same characteristics, including prior MRSA infection, prior and prolonged vancomycin therapy, and renal disease needing dialysis. The two drugs that have been effective so far against these two infections are Zyvox and Centercid. Problems from inadequate antimicrobial therapy. Inadequate antimicrobial therapy may range from an incorrect choice of drug to poor patient adherence. Some infections relapse in a subtle fashion. Drug regimen non-compliance, which is a deliberate failure to take the drug, or non-adherence, which is accidental failure to take the drug, prevents contact of harmful microorganisms with sufficient concentrations of the drugs and contributes to resistant organism development. Some diseases like tuberculosis have legal sanctions that require that a patient complete treatment. They have what we call directly observed therapy, where the healthcare worker must actually see the patient take the medication. Serious complications of infection may also result from incomplete or inadequate antibiotic therapy. If an infection is not resolved or if it is treated with drugs that are ineffective for the offending microorganism, the pathogen may enter the bloodstream. This is known as septicemia or bloodstream infection. Once a patient becomes septic or develops septicemia, if we are not vigilant with antibiotic treatment, it may progress to septic shock. In septic shock, insufficient cardiac output is compounded by hypovolemia. Inadequate blood supply to vital organs leads to hypoxia and organ failure. And ultimately, septic shock can lead to the death of the patient. Okay, on to collaborative care of the patient. The first thing we want to do is get an adequate history of the patient. So we're going to need the age, the history of tobacco or alcohol use, any current illnesses or diseases, any past and current drug use, such as steroids, any other over-the-counter medications, any prescribed medications, any recreational medications, or recreational drugs, should I say, and their nutritional status, history of recent exposure to someone with similar clinical symptoms or to contaminated food or water, as well as the time they've been exposed. Ask about recent animal contact at home or work or in leisure activities, any recent insect bites, have they been hiking, their travel history, have they traveled outside of the country. A thorough sexual history may reveal behavior associated with an increased risk of sexually transmitted diseases. We now call them sexually transmitted infections. A history of IV drug use and a transfusion history to assess the patient's risk for Hep B, Hep C, and HIV. Now on to our physical assessment. We're going to inspect the skin for symptoms of local infection at any site. And symptoms of local infection include pain, swelling, heat, redness, or pus. We're going to check to see if the patient is febrile, generally a temperature above 101. They may elicit chills and malaise, and those are primary indicators of a systemic infection. Lymphadenopathy, pharyngitis, and GI disturbances, usually diarrhea or vomiting, are often associated with infection. You want to ask about a change in the patient's stool and if the patient has had any nausea or vomiting. You want to assess the patient's and family's level of understanding about various diagnostic procedures and the time required to obtain test results. Plan education on infection risk reduction at a time when the patient and the family are ready to learn. Feelings of malice and fatigue often accompany infection. Assess the patient's current level of activity and the impact of these symptoms on the family, their work, and their recreational activities. You want to determine the patient's and family's understanding of the infection, the mode of transmission, and mechanisms that may limit or prevent transmission. Laboratory assessment. If the patient has an infection or we think the patient has an infection, you may see a culture and antibiotic sensitivity testing done. The culture or isolation of the pathogen by cultivation in tissue cultures or artificial media. Antibiotic sensitivity testing is performed to determine the effects of various drugs on that particular microorganisms. Preliminary results are usually available in 24 to 48 hours, but the final results generally take 72 hours. One thing you want to remember as a nurse, you never want to start your antibiotic therapy until the cultures are done. Once the cultures are done and they're sent off to the lab, You may then start your antibiotic therapy that is ordered by the physician. Typically, we put them on broad spectrum antibiotics. And once we get back the results of the culture and sensitivity, we find out what bug it is and what antibiotic will kill the bug. We then, or the physician will then change the prescription to something that is more conducive to eradicating that bug. Another lab value we may see is a complete blood count with differential. It is often done for the patient with a suspected infection. In active infections, total leukocyte count is elevated. The differential count usually shows an increased number of immature neutrophils, and we call those bands. And when you see an increase in your bands, we call that a shift to the left. Usually whenever you hear someone says, oh, she has a left shift, more than likely we're thinking this person has some type of infectious process going on. Another test you may see is the erythrocyte sedimentation rate. You'll either hear it say called ESR or SED rate. It measures the rate at which red blood cells fall through plasma, and it occurs with inflammation. Chronic infection, especially osteomyelitis and chronic abscesses, are commonly associated with an elevated sedimentation rate. Serologic testing is performed to identify pathogens by detecting antibodies to the organism. It increases during the acute phase of the infectious disease, such as hepatitis B. The titer decreases as the patient improves. Imaging assessments include X-ray films may be obtained to determine activity or destruction by an infectious microorganism. A computed tomography or CT scan and MRIs help identify suspected osteomyelitis and fluid collections that point to possible infection and abscesses. MRI scans provide a cross-sectional assessment for infection. Ultrasound is a non-invasive procedure particularly helpful in detecting infection involving the heart valves. Scanning techniques using radioactive substances such as gallium can determine the presence of inflammation. Inflammatory tissue is identified by its increased uptake of the injected radioactive material. Home care management. When we're sending the patient home, we want to emphasize that there's a clean home environment. They may have nurses or home health aides go out to inspect the patient's home to make sure that they're going to a clean environment. As the nurse, we want to do health teaching. We want to explain the disease, infection, and precautions, the disposal of sharps, completion of their medications. This is why we have so many multi-drug resistant organisms. We have to teach our patients that they need to take the full course of their antibiotics. Many people take their antibiotics, and as soon as they start feeling better, they stop taking them and they don't complete the prescribed length of medication. So we must teach our patients to take the full course of their antibiotics. Healthcare resources, these people, if they can't go home or if their home is not clean and safe, they may need to go to a SNF, a skilled nursing facility, or they can go home with home health, or sometimes patients are even put onto rehab floors or go to rehab facilities. Now I'm going to show a video that talks about the inflammatory process.
Tissue to local injury. Acute inflammation is the early, almost immediate reaction of tissue to the injury, and it is the first phase of wound healing. Acute inflammation can be triggered by cell or tissue damage, or by the presence of dead cells or noxious agents such as bacteria. Acute inflammation typically occurs before the immune response becomes established and aims primarily at removing the injury-causing agent and limiting the extent of tissue damage. Acute inflammation occurs in two overlapping stages, vascular and cellular. In the vascular stage, arterioles and venules near the site of injury constrict briefly, then dilate. Dilation promotes congestion, while an accompanying increase in capillary permeability leads to the movement of fluid into the affected tissue, resulting in the 5 classic signs of inflammation: redness, swelling, heat, pain, and loss of function. As fluid leaves the capillaries, the blood remaining in circulation becomes more viscous, it flows more slowly, and clotting occurs. The cellular stage of acute inflammation is initiated by the movement of phagocytic white blood cells, or leukocytes, into the area of injury. The leukocytes begin to adhere to the vessel wall, and then, in a process called emigration, squeeze through the wall and move into the inflamed tissue. The leukocytes wander through the tissue, guided by chemical signals in a process called chemotaxis. The cellular stage culminates in the leukocytes engulfing and degrading the bacteria and cellular debris in a process called phagocytosis. Products of phagocytosis, along with plasma and blood cells, form exudates, which accumulate, causing swelling and pain. Exudates are composed of serous fluid, red blood cells, fibrinogen, or tissue debris, and white blood cell breakdown products. Concurrent with the events of the vascular and cellular stages, chemical mediators release bioactive agents that act to mediate the inflammatory response. Mediators are derived from the cells or from plasma. One of the first mediators of an inflammatory response is a cell-derived mediator, histamine, found in high concentrations in the mast cells of connective tissues adjacent to blood vessels, as well as in blood basophils and platelets. Histamine is released in response to a variety of stimuli and causes dilation and increased permeability of capillaries. Serotonin, another cell-derived mediator, performs similar actions. The 3 major plasma-derived mediators are present in the plasma in precursor forms that must be activated, usually by a series of proteolytic enzymes. The kinins increase capillary permeability and stimulate pain receptors. The clotting system traps exudates, microorganisms, and foreign bodies. The complement cascade causes vasodilation, promotes leukocyte chemotaxis, and augments phagocytosis. Acute inflammation comprises a variety of complex protective responses to injury that, together, lay the groundwork for the next stages of the body's recovery: immune response and tissue repair.
Okay, let's do a case study. We have a 27-year-old patient who is admitted from the ED to the med-surg unit with cellulitis of the left leg. A culture result from her primary care provider's office indicated she was positive for MRSA in the leg wound. Based on this information provided through the SBAR report, what type of isolation room should the nurse prepare the patient when she arrives on the unit? The answer is this patient should be admitted to a private room under contact isolation precautions, or she can share a room with another patient who has MRSA. After the patient is settled in her room, what special precautions does the nurse implement based on her diagnosis? Select all that apply. A. Wear gloves when entering the room. B. Wear a mask when working within 3 feet of the patient. C. Wear a gown to prevent contact with contaminated items. D. Keep the door closed at all times. E. Dedicated equipment should be used for this patient alone. I'll give you guys a minute to think about it, then we will go over the answer. The correct answer options are A, C, and E. The rationale: the patient should be taught to perform frequent hand washing. Healthcare personnel and visitors should wear gloves upon entering the room to prevent contact with the patient, contaminated items, or if the patient has uncontrollable body fluids. Hand washing should be performed before leaving the room. There should also be dedicated equipment for this patient to prevent the spread of infection. A mask should be worn with airborne and droplet precautions, and the door should be kept closed with airborne precautions. So that's why those options were incorrect. An hour later, the nurse is preparing to administer the patient's medications. Which drug was likely ordered by the provider to combat the patient's MRSA? A. Amoxicillin or Amoxil. B. Ciprofloxacin or Cipro. C. Erythromycin or Erythrocin. D. Vancomycin or Vancomycin. The answer is D. The vancomycin. MRSA is susceptible to only a few antibiotics such as vancomycin and Zyvox. After lunch, the patient asked how she could have contracted the MRSA infection. What is the nurse's best response? A. Some people who travel to third world countries return with this infection. B. The most common way of MRSA to spread is through coughing illnesses such as the flu. C. MRSA is spread by direct contact in hospitals and communities. Or D. In the community, MRSA is transmitted by the airborne route carried by droplets. The answer is C. MRSA or MRSA is spread by direct contact, such as with indwelling catheters, vascular access devices, and endotracheal tubes in the hospital and community settings. Case study number 2. The home health nurse is visiting AJ, a 75-year-old woman who is 2 weeks post-coronary artery bypass surgery and has an infection in her left lower leg where the saphenous vein was removed to use for graft replacement. The area is open in 2 places, one near her ankle and one near her knee. The one near the ankle is 3 inches long, 1 inch wide, and 1 inch deep. The one near her knee is 3 inches long, 1.5 inches deep, and 1 inch wide. Thick yellow fluid drains from both sites. What should the nurse expect to see in the results of AJ's complete blood count laboratory test? The answer is an elevated white blood cell count or leukocytes. And the rationale for that: in most active infections, especially those caused by bacteria, the total leukocyte count is elevated. How should the nurse treat AJ's fever if she has one? Answer: administer antipyretics and drug therapy, such as antimicrobials, antibiotics, antivirals, or antifungals, to kill the microorganism causing the infection. The rationale: the primary concern is to provide measures to eliminate the underlying cause of fever and to destroy the causative microorganism, and with this, drug therapy plays a major role. Is AJ's own hand washing important to her outcomes? Yes, her ability to wash hands correctly impacts her health outcomes. The rationale: correct hand washing techniques decreases transmission of microorganisms When the patient is performing wound care, the patient's hands must be washed first to decrease the risk of causing wound infections. Now on to some review questions. Cleansing hands with alcohol-based hand rubs is appropriate in which situation? A. After administering medications to a patient. B. After working with a patient who has diarrhea due to Clostridium difficile. C. After using the bathroom. D. To cleanse visibly soiled or sticky hands. I'll give you guys a minute to think about that before I give you the answer. The answer, and everyone should have gotten this one right. A. Alcohol-based hand rubs are not appropriate if one's hands are visibly dirty, soiled, or feel sticky, or you have just toileted. In these cases, wash your hands instead of using alcohol-based rubs. Your alcohol-based rubs are also ineffective against spore-forming organisms such as C. difficile or Clostridium difficile. Next question. A patient who has been admitted for newly diagnosed tuberculosis will be placed on which transmission-based precaution? A. Droplet precaution. B. Airborne precautions. C. Respiratory precautions. Or D. Contact precautions. Take a few minutes, a few seconds to think about it. The answer is B. Airborne precautions are used for patients known or suspected to have infections such as tuberculosis that are transmitted by the airborne transmission route. Droplet precautions are used for patients known or suspected to have infections such as influenza and mumps that are transmitted by the droplet transmission route. Contact precautions are used for patients known or suspected to have infections transmitted by direct contact or contact with items in the environment. The term respiratory precautions does not refer to a current transmission-based precaution protocol. A patient may have infectious mononucleosis and is awaiting laboratory confirmation of this diagnosis. If the results are positive for infectious mononucleosis, the nurse would expect to see which laboratory result? A. An increase in neutrophil levels. B. A decrease in neutrophil levels. C. Decreased erythrocyte sedimentation rate. D. Increased lymphocyte levels. Take a few to think about it. The answer is, it's the wrong slide. Hold on. Okay. Okay, here we go. The answer is B. The rationale: a few infectious diseases, however, such as malaria and infectious mononucleosis, are associated with neutropenia, which is decreased neutrophils. An elevated, not decreased, erythrocyte sedimentation rate indicates an inflammation or infection somewhere in the body. Okay, next question. Which person has the highest risk for having Clostridium difficile associated disease? A. A poultry farm worker. B. A person who has eaten a hamburger that was cooked rare. C. A 2-year-old patient who has received IV antibiotics for a week. D. An 82-year-old patient who has received IV antibiotics for a week. I'll give you a second to think about that. The answer is D, and the rationale is C. diff is associated with antibiotic therapy, and older adults are the most at risk for this infection. Contact with infected poultry may lead to the development of the avian influenza strain or bird flu. Recent episodes of illness after eating contaminated fresh spinach, ground beef, and other foods were associated with E. coli. This concludes the end of your lecture on Chapter 25, The Patient with Infection. If you have any questions, please be sure to call or email or ask me when you see me in the hallways. Thank you.